Okay, it is 10:01 and we have cleared the waiting room. Beth, are you on? She may not be on yet, so let's give it just a second longer. It looks like Beth is joining now, so we'll give it just a few minutes for her to get logged in.
Morning.
Good morning. The waiting room is cleared, so if you would like to start.
Okay, very good. Call the order, and I'm going to take the roll call.
Did you need me to do that today, or is Heather on?
I don't know if we have the secretary or not.
Okay, I have got the list ready. So Beth,
Here,
Nina,
Here.
Susan won't be here today. She sent us an email. Dr. Roberts, Heather Smith,
Here.
Dr. Bobrowski, I thought I saw him logged in. Maybe we lost him. Dr. Compton,
Here.
Dr. Mueller,
Here.
Dr. Gupta is not going to be with us today. John Dadds, Dr. Hannah, Barry Martin,
Here.
Kent Gilbert, Mackenzie Wallace, Anissa Franklin, Dr. Schuster,
Here.
Brian Proctor, Peggy Rourke,
Here.
Eric Wright.
I'm here. Thank you.
And I'm here, Bobrowski.
Sorry, I lost count. Give me 1 second. I'm sorry. I counted 10. So we should have a quorum. You're good to go.
okay, great, thank you. Next up is approval of the minutes. Would somebody like to make?
I'll move for their approval. This is Sheila Schuster.
Second, John Muller.
Thank you. Any discussion? All in favor, say aye.
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 Any opposed? Okay, thank you. Minutes are approved. Old business. What is the status of Anthem MCO? And I guess this goes to Commissioner.
Good morning. Still in litigation. No new updates on this topic.
Okay, thank you. I'll put that up for next meeting. Has the letter to the governor on the workforce study, has that been sent?
No, we did discuss this with the secretary's office, and we thought and believe that since we were in the midst of a workforce study already, that the letter should not be, did not need to go to the governor. So the secretary did make that decision. Secretary's office did make that decision. So we do have, and I can jump into C because it's related to B. We do have a preliminary workforce study report. I have reviewed the report. I think it's got some very good information in there. We will be finalizing that next week, and we'll send that out to the MAC and the tax for review, and we can discuss it at the next MAC. If you all would like a presentation on the report, we can definitely present on the report after you review, ask and answer any questions that you may have, and talk about some of the things that we're going to do going forward. For example, we do have a state university partnership that is also going to be looking at some access and some workforce that we may be able to fold into this after you look at the report and have your questions.
Okay, thank you, Commissioner. And that would be related to C, right? The UK analytics.
Yes.
Study?
Yes.
Okay, so let's put that on the agenda for the next meeting.
Yes, we can definitely have a report out, a presentation on the findings of the workforce study.
Okay. Sorry, I'm making notes. Okay. And then the next item is just a reminder about the update on canceled appointments. And that will be for the September meeting. And then PDS legislative rate increase. And Eric, if you would like to speak to that.
Yeah, first I want to just thank Commissioner Lee and Pam Smith for meeting with me on Wednesday, June the 21st. We had about an hour meeting to discuss the PDS rate increase and some of the communication that is being sent out to the agencies that oversee PDS services for individuals with intellectual and developmental disabilities, primarily through our 1915C waivers. Commissioner Lee and Pam agreed that we are working towards a goal of communicating with consistency, whether it be case managers, support brokers, or however agency describe the individuals who help families navigate PDS services with those waivers. I felt very positive about the meeting, and obviously there was a need to have this discussion as it continues to be a little bit of confusion within the community and social media related to how these rate increases are being communicated to representatives across the Commonwealth. In that, though, I do suggest that we get a little bit of an update from Commissioner Lee on any developments, or Pam, if she would take a few minutes to reflect upon the meeting and some of the results of those discussions.
Thank you, Dr. Wright. I think that the meeting went well too. I think always, working on our communications is a good strategy. And Pam, is Pam on the call today? And if she would like to provide any additional comments or updates related to the conversation we have with Dr. Wright.
Thank you, Commissioner. So we are working on a communication that has, in addition to Eric, some of the things that we talked about as far as the timing, and that families, so that families weren't told you have to wait till you research, some direction around that, when a family reaches out to you and they need to modify the plan of care, then part of the responsibility of the case manager / support broker / PDS coordinator. That's one of the things also we're changing, to give everybody one name so that we don't have 15 different names for different programs. That needs to be handled like any other plan of care change, and that it needs to be scheduled timely. So we are working on that communication, as well as the communication about the second rate increase that just went in It was effective July 1st. It will actually go into the system tomorrow night. We are going to go back and mass adjust claims from July 1 until that goes in tomorrow night. But that communication is going out hopefully this afternoon. If not, it will be out tomorrow. But we are working with our partners with the ads and the CMHCs. And also another exciting thing that we're doing with, in particular, participant directed services is we have expanded the availability of that so that it is similar to SCL and that any certified case manager can perform those functions. So we're beginning to see some of our other case managers start picking up individuals for PDS that maybe were not in a waiver they served before, or it may be in the same waiver, but they did not do participant direction before. So that is growing and is expanding.
Thank you, Pam. Pam, can you speak to a conversation that you and Commissioner Lee and I had related to with the rate increases? There was a discussion about a request to CMS about, and I guess it was related to budget increases related to the waivers as well, and how that might be addressed. I believe there's a plan that you all have in place with CMS. Is that correct?
So right now in particular, and I'm sorry, my dog has decided he is going to talk right now. So
No, that's okay.
I apologize for the noise in the background. Right now there are, Michelle P in particular, there in the regulation, there is a budget amount. There's a limit of 40,000 if a plan is only participant directed services, and 63,000 if the plan has both traditional and participant directed services. So through Appendix K, we have waived, there are a lot of, actually, we waived several limitations, but one of them was that budgetary limitation. Because one, it does not make sense that we're going to increase the rates, but then we're going to leave an old budgetary cap in there, which would, result in individuals either not being able to give their employees a pay increase, or B, them not getting the amount of services that they needed. So we, as part of the initiatives right now with us modifying the waivers and rewriting the regs to reflect the rate increases, we are looking at that at all limitations. And so that would be limitations on the amount of service hours a week, as well as limitations, those budgetary limitations. But we are not enforcing that $40,000 and $63,000 amount right now. So it allows the individuals to have access to be able to pay their employees a fair rate based on the rate increases.
Thank you.
You're
Thank
very
you.
welcome.
Okay, thank you all. Next up, we have a report from DMS about community health workers and how they function.
Yes, I think Justin Derringer is in the meeting, and he will be providing an update on this. Justin.
Hello, thank you, Commissioner. Yes, we started July 1st providing reimbursement for community health workers for several provider types. And we'll go through a little presentation now to talk just a little bit about that. So some of the qualifications for being a community health worker, you have to be a legal United States resident. You have to be employed as a community health worker in the state of Kentucky, be at least 18 years old, and meet and maintain the certification or recertification requirements. Those certification and recertification requirements are put in administrative regulation through the Department for Public Health, and they are maintained there. Some of the services that a CHW can provide: the preventative services, health promotion and education, facilitate provider communication, patient education, and other approved DMS services. A couple of things that we as in the Department for Medicaid Services and meeting with providers and provider groups, we're able to see something that you had brought up earlier was no-show list. One of the things that we continue to strive and fight against are what are the causes of individuals that are Medicaid recipients not showing up or not canceling appointments. And part of that process is finding out exactly why they're not showing up so that we can attack those different areas. Some of those things can be found out by using community health worker services. Community health workers provide services that, again, you'll see one of these says facilitate provider communication. They reach out to individuals to see if they've changed phone numbers, changed email addresses, to make sure that they're getting their notifications for their appointments, to make sure they understand that they have to cancel appointments and give notifications. In addition, we talk about other approved services and patient education. Those things are part of how to access services such as transportation services, non-emergency medical transportation, other forms of assistance that they may need in order to get to their appointments, as well as being able to find out, reach out and find out reasons why they may have missed an appointment, which the biggest percentage of when that report comes out of no-shows, the biggest percentage of no-shows, just there is no reason or given. And so community health workers can also help with that, to be able to pinpoint reasons why individuals weren't able to show up. All right, next slide. The health navigation and resource coordination is vital for community health workers to provide. It helps them to find Medicaid providers to receive covered services. A lot of times Medicaid recipients and individuals don't know exactly which provider may provide the best service to them. And a lot of times they'll end up going to an emergency room or to a improper provider for certain services they need. Helps them make appointments for Medicaid cover services. This also encompasses helping them to cancel appointments, change appointments for other needed items, arrange appointments that are together, arrange transportation to medical appointments, attend an appointment with the recipient for a covered service if they are in need of understanding what's going on or understanding having certain communication barriers. Help a recipient find other relevant community resources such as support groups and other areas of support for the recipient. Health education and training. Education and training for health issues such as immunizations, managing blood pressure, managing STDs, diabetes, accident prevention, occupational safety, and control of toxic agents or poison control, all assist us with promoting better health for individuals in the long run, and at the same time keeping costs down to the medical community. Health promotion and coaching, cessation of tobacco use, reductions in the misuse of alcohol or drugs, improvement in nutrition, improvement of physical fitness, family planning, control of stress, pregnancy and infant care, including prevention of fetal alcohol syndrome. I spoke with a physician yesterday over the phone that talked about the multiple times and the amount of time that he spends with multiple individuals going over cessation of tobacco use or improvement in nutrition in his clients when he discusses nutrition in themselves and in some of the younger patients that he sees. These things can be done by a community health worker who are trained in these different things, and it allows clinicians more time to see more patients and to be more successful. So providers, what type of provider can bill for community health workers? Right now, we have alcohol and other drug treatment entities, behavioral health service organizations, community mental health centers, FQHCs or federally qualified health centers, a health system consisting of a hospital or at least a group of physicians or more than one group of physicians, a hospital, a local health department, primary care clinic, a rural health clinic, and then there are some other Medicaid participating providers, such as dentists and midwives that are also able to bill for community health workers. Some other requirements for community health workers, they cannot enroll as independent Medicaid participating providers. They have to be employed by one of the current Medicaid enrolled provider types. They must be related, the services they provide must be related to medical intervention outlined in the individual's care plan. There's no reimbursement for CHWs that are already paid by federal funds through grants or other means. If reimbursement is already included in a per diem or cost settlement type, they're not reimbursed for, or for CHWs that are employed by managed care organizations or MCOs. And CHWs are not eligible for RAT payments. Those are some of our billing codes currently, most up-to-date billing codes that we use for CHWs. You can see their CPT 98960 through 98962. And basically they're the same CPT code that just deals with how many individuals the CHW is working with at that moment. And they're in 30-minute increments. So MCOs hire their own CHWs and they reimburse them a fee for service Medicaid, reimburses for CHWs for all different providers. So the other thing is that there are set limits for some of the community health workers that they can exceed, but those are broken down by provider type groups. So that the limits aren't strictly per individual. So if an individual goes to a physician today and sees a community health worker, and then on Wednesday they go to see their dentist and a community health worker assists them there, and then on Friday they go to see their therapist and a community health worker sees them there, they're able to do all those things within the same week, and those limits don't reflect on each other because they are different provider type groupings. So that's all I had for that. I appreciate you taking time to listen to me. Do you have any questions or?
Justin, I have a question.
Sure.
So community health workers are not something that DMS provides. These are people who are hired by providers to provide services in different practices?
Yes, ma'am, absolutely. So a lot of our different provider types hire community health workers to assist them in many different avenues of what they do. And community health workers are varied. Currently, there are many types of grants that are used to hire and provide community health workers, and each grant's very specific on what they may do. Currently some of the managed care organizations we have in our state hire or have on staff community health workers, and they do more of the varied duties that our providers can use these community health workers for. So whether it's taking the time that a physician would sit down and go over nutritional needs or values with a patient and freeing up the clinician that way, or if it's assisting an individual with scheduling and learning transportation services to make sure that their no-show rate goes down. All those things can happen through the providers that are hiring these community health workers.
So I received letters from various MCOs saying that the participant has been contacted, and they talk about their blood pressure, they talk about smoking, it goes through a whole list of different things. Are those community health workers that are doing that?
Oh, it depends on the managed care organizations, but I would say in a lot of cases that, or in some cases, it definitely is a community health worker that does that.
Okay, thank you.
Dr. Bobrowski has his hand raised. Oh, I'm sorry, Beth.
I was just going to say, did anybody have any questions?
I got one question. Justin, can local health departments hire, I didn't see that. I may have missed it on your list of different provider types that could get community health workers. So I didn't know if just local health departments qualified to hire somebody there.
Yes, sir, absolutely. If, as a matter of fact, on the front page of our Kentucky Medicaid website, if you will look, on the right-hand side, we have two different links for community health worker information. One of them is the, presentation that I just went over, but the other one is a very extensive, fact sheet and FAQ sheet that details exactly what provider types are eligible to bill, the limitations, the CPT codes, and many other questions that providers have asked us, and we've added to that list to help individuals understand, all the different ins and outs. It's a brand new service, so there are a lot of things that we're still working on as well.
Thank you.
Can we, I'm sorry, Eric, can we get a copy of this presentation emailed to us? Or is it on the website?
It's
It'll
it's
be-
currently on the website,
Okay,
yes,
thank you.
but Aaron's can send it out too. And I believe that Deputy Commissioner Veronica Cecil has already put the FAQ link in the chat as well.
All presentations are emailed out to the MAC afterwards and then uploaded to the website.
This is Susan Rittenhouse, 7 counties. I have 2 questions, please. The first one is in regards to the certification. With some provider types, an individual can be hired and has a certain amount of time that they can work, say up to 6 months while they're getting that certification. Is there a time frame for that with community health workers?
So that's governed by the Department for Public Health Services. And at this time, I don't think that there's that grace period. I'd have to go back and look at the administrative regulation. I don't remember if there's if you're allowed to bill for community health worker services before they get that training. I don't think so. I'd have to go back and look to be 100% sure, but I can go back and look at that. I know for sure in their administrative regulation that that before you get your certification, you have to complete a small amount of training from them. But that training, to my understanding, is always available, so they can do that online at any time, and it's not a large amount of training. But I would have to go. I don't believe that right now it's reimbursable, like you said, pre-certification. But it's something that's one of the issues. Like I said, we've started this July 1st, so it's a new service, and there are a list of topics that we have that we're meeting on currently, or that we have meetings set up to discuss. To come up with some solutions and recommendations that we've gotten feedback from providers. And what you just mentioned is having community health workers set up kind of like peer support service workers. When they start, they have a certain amount of time to get their certification, and they're still able to reimburse as long as they're under supervision. That's
Correct.
something that we've discussed as well. So a lot of different things that we've looked at. We're trying to make the process for payment for dental providers smoother and easier. We're looking at limitations, all those things that we're talking about and discussing. So, but thank you for bringing that up, and I'll try to find out exactly, but I'm pretty sure that that's not current.
Justin, this is Commissioner Lee. Yes, you are correct, Justin, that the CHW, the community health worker, does have to be certified in order for the provider to bill for their services. Now,
Okay.
providers can hire individuals that they think or that are working towards their certification and have them in the office, getting them familiar with the services array and their members that they serve, but they cannot bill for that community health worker until the community health worker receives their certification.
Okay, thank you. My second question is a little more complex, and you may not have an answer, but would like to at least put it on the radar. I know that community mental health centers are eligible for this provider type. 4 of the community mental health centers in Kentucky currently are also CCBHCs, and I understand that this code is not eligible for RAP payments. My question is that the CMHCs have received correspondence that we cannot bill for outpatient CMHC services if we're a CCBHC on the same day as a CCBHC service? Is this code going to be exempt from that requirement so that we could provide this service as a CMHC on the same day that there's a CCBHC service being provided?
That's a good question, and it is an in-depth question. So let me take that back and get an answer back to you. So I'll give you a answer 100%.
Thank you very much.
Hi, this is Eric. I had a question too. Two quick questions. First off, when you look at this, Justin, give me an example of about how much time training goes into this, and as you see people unfolding kind of this and launching this into their agencies, are they advertising these positions with a certain salary range? And if so, can you kind of give an average of what these people are being paid?
So right now, the average amount of training time just depends on, again, if they're certified, if they're already certified, it's very minimal. Being able to describe exactly what you are looking for this CMH or the community health worker. Each provider type will, and each individual provider will have different needs for that CHW services. Some may need individuals to strictly focused on no-shows and reducing that no-show rate. Others will want them working on nutritional education or whatever their priority is for those individuals. I know spoke with one provider last week, and they have a lot of their office staff that are constantly working on assisting individuals with helping them kind of go through the paperwork and the processes of just the visit itself. And so they were getting backed up in their office where a CHW would be able to assist an individual with that type thing. So every provider kind of will be different. And as far as pay range, we don't have that information yet. We have some preliminary information from the MCOs, but I'm not sure that really correlates. So I would hesitate to give any of that information because we just started the services July 1st. I think toward the end of the year, we'll have a better understanding of how much these individuals are being paid and what some of their specific roles that providers have hired them for. And we can kind of give out some reports and look at some assessments based on those things. I don't know if you had any more, Commissioner Lee, but.
One real quick follow-up is, and can an individual start this certification process without being you could say, hey, here's an opportunity for someone to start this certification process and become certified without having an agreement to be hired?
Absolutely. So someone can become a certified community health worker. They just can't be reimbursed through Medicaid until they're employed by a enrolled provider type.
So is there an educational program for these people to attend? Is it a formal educational program?
There are a set standard of education that they have to obtain from the Department for Public Health.
Okay, so
The
that's where
Department of Public Health has a program that they go through, and they have educational requirements that they approve that has to be met in order for them to get their certification through the Department for Public Health.
Okay, thank you. Anything else?
Madam Chairman, this is Steve Compton. I do have a question. But why are optometrists not listed on those that can hire community health workers?
So optometrists are listed as in that services, and I believe that they're lumped into the maybe the one of those groups. I can't remember.
CMS defines us as the physicians. It could go under that.
That's where it's at.
Okay.
I apologize. I'm trying to pull up my FAQs, but I think they're grouped into the physician group.
I've got it in front of me, so I just.
Okay,
Thanks
there
for
you go.
clearing that up. Thank you.
Sure.
Bye.
Okay, any other questions? Okay, thank you, Justin.
Thank you.
Next up, we have update on maternal and child health.
Hi, this is Dr. Terrio. I'm not sure what screen you guys are seeing. I hope you're seeing slides.
We are.
Oh, good. All right. I just wanted to give a little update on maternal health. And this should not take too long, but I wanted to talk first a little bit about the dashboard that we've been talking about. It's not ready yet. It's still in production, but I wanted to give you just a snippet about what we're planning. Oops, I cannot get that. Why can I not advance? Well, anybody have any ideas? It worked. Okay. So the maternal health data contain maternal data, but we'll have some child data as well. Child data is going to include like ER visits, well child visits, immunizations, and the maternal data will have types of deliveries like C-sections versus vaginal deliveries, if the baby was term, preterm, late term, and then different categories of if mom received certain screenings, if there was a doula involved, the smoking status, in ICU admissions, things like that. And so when you go into the dashboard, you'll have a drop-down list and you can sort the data by year. And this is, in this example, it's sorted to 2020. You can sort by managed care organization. So you can just look at data from all of the MCOs, or you can look at specific MCO, or you can look at fee for service. It's also broken down by race and ethnicity. So that's the main toggle that you can see. And so these are just little examples. So this is the example of the type of delivery. And I picked 1 year and picked all deliveries for that year. And so you can see we had 16,000 or so vaginal deliveries during that year and 9,286 C-sections. Then we broke the C-sections down a little bit more. Was it a primary C-section, meaning it's the mom's first C-section versus a repeat C-section? And you can see how that breaks down. Now you can take this graph and you can break that down by race. You can manipulate the graph a little bit. This is an example when I just changed it from all MCOs to one MCO. And so you can see the difference there. Like in this one MCO, the primary C-sections were 25% of the births versus, what was it, 21% for everybody together. And then again, you can do it for race or whatever you happen to be looking at. So I broke it down by race, and on the left, you see it's all MCOs for a year of births for the Black race, and you can see let's see, the primary C-section rate was 20.64, and then on the right side, and you move this out of the way, the primary C-section rate for the white women was 21.08. So fairly close. But again, you can just break it down how you really want to look at things. This is an example. Again, this is 1 year, and I keep moving our little pictures around. This is 1 year of data, and you can click on, let's see, November of 2020. And if I was in the interactive when this, or actually this red one, would click on this and I can see that 25% of the moms that gave birth during that month of that year smoke cigarettes. And again, you can break it down by the different things as well. Just a glance at the child data, you can click on an age group and a month and a year, and you can see how many children had a well child visit during that time, or a vaccination or an ED visit. We're trying to add in the COVID vaccinations as well. And then you can sort, just like we talked about, the same categories of sorting. Do you guys have any, go ahead. I'm sorry? Does anybody have any questions about the dashboard?
Dr. Terrio, this is Sheila Schuster. I guess I'm curious about, were you all curious about where people were giving birth?
Yes, what I didn't show you.
Home, hospital, and if we ever get birthing centers, and if they're in Kentucky or elsewhere?
Yes, we can do that. We also have it broken down by county. And then what I didn't show was also a list of top 10 diagnoses for women that were admitted to the hospital postpartum, and top 10 diagnoses for women that had an ER visit postpartum. And I couldn't show all of this. I really would have liked to do it interactive. Number one, I was really worried that the internet wouldn't cooperate if I did that. But because it's still in production, I really couldn't show a lot of the detailed information yet.
Yeah.
But yes, and I think all of those things are very important to look at, because again, it'll show us a snapshot. It'll show us trends. So if we make a big intervention, for example, the extending care to 12 months postpartum, we know the day that went into effect, and then we can follow it out to see outcomes, if it had anything to do with our outcomes, or if an MCO makes a big change in, with doula care or something like that, we know when that started. We can see how that's helping our population. So I'm really excited about it, and it should be done soon.
This is Sheila again. It would also be helpful to have, I'm so glad you're going to have the top 10 diagnoses for admission postpartum, because with Senate Bill 135 passing and our emphasis on more education and maybe getting more treatment providers out there for perinatal mental health issues, be interesting to follow that data as well. Thank you.
Yes, thank you. And I didn't point it out, but in that squiggly line graph, you can also look at if mom was screened for substance use, if she was screened for SDOH, if she was screened for postpartum depression. So that will all show up in that graph as well, that you can break down.
Super. Thank you very much.
Thanks.
And that will be on the MS website?
Yes, that's our plan.
Great.
And then I wanted to real quick, the 2022 maternal mortality review report came out this month. It's always a little bit behind. And I wanted to give you a few highlights from that report. Our maternal deaths actually stayed about the same as they were last year. We had 63 maternal deaths in 2020. And again, this report is produced from the work of the Maternal Mortality Review Committee. And that committee takes a look at every single maternal death, or a death of a mom, either while pregnant or within 365 days of being pregnant, and drills down and looks at every single death happened. Was it preventable? What were risk factors leading up to the death, if any? And then what can we do to change it? And so it takes a lot of time to go through these reviews, which is why, you know, this is so kind of behind, couple years behind. And I can tell you, we had a meeting earlier this week, and they're usually 6-hour meetings. Only got through 10 cases we're going into with each one of the cases. So you can look in 2019, we had 61 deaths, and in 2020, we had 63 deaths. Kind of holding steady. 2018 was a bad year with the 76. When we look at the pregnancy-related deaths, and those are the deaths that happen because of the pregnancy. You know, it wouldn't have happened if the mom hadn't been pregnant. Those are holding steady as well, and our 2019 rate is 16.9. The 2019 United States rate, national rate, was 20.1. And so these are the ones I think of as it's a hemorrhage, it's a heart problem, it could be eclampsia. You know, these are the medical deaths that happen. Now, not to say that they should have happened, or, you know, because a lot of them are preventable, but these are a little bit different. That big number of 61 that encompassed every death, that obviously most of them had nothing to do with being pregnant. They, you know, it could have been an overdose, it could have been a car accident, are natural that we looked at, and a good number are accidental deaths, and then you have homicides and suicides. A lot of those accidental deaths, I can tell you, are overdose deaths. And when we dive down and look at all the records, at least the committee has questions that maybe some of these ones that are deemed accidental are actually suicide, but without an actual note or something like that showing intent to commit suicide, you can't deem it suicide legally. So even though it's such a high number of accidental deaths, I really think some of those really should move over to that suicide category, and we need to do something about that. Speaking of drug overdose deaths, we have about 50% of our moms in that accidental maternal death category that die because of overdoses. And that is a huge number. That is why our maternal death rate is so high in Kentucky, is overdose deaths. And it's higher than the rest of the nation. In case you're wondering about racial disparities, we still have a huge racial disparity. About half or twice as many maternal deaths occur for Black women compared to white women, and we still have to work on that. And so really what we gleaned from that 2019 cohort is about 20% of the deaths were pregnancy-related deaths, at 16.9 deaths per 100,000. Overall deaths from all causes, we were at 115.1 per 100,000. 54% of the mortality cases had substance use linked to their death. And almost 90% are preventable. And when you look at the national deaths, but
Dr. Terrio, you keep
89% are preventable.
You keep kind of
Oh, I'm
going in
sorry,
and out
did
a
I-
little bit, Dr. Terrio. Yeah.
Out. Oh, okay. Oh, should I just repeat this slide? All I was saying was that the about half of our cases, 54% of our mortality cases have substance use linked to their death. and 89% of our cases are deemed preventable of all of the cases. And nationally, the CDC says 60% of the deaths are preventable. And our number is so high because of substance use. And so really, if we wanted to make a difference, we really need to focus on the substance use and opioid epidemic. I think that's it. Do you guys have any questions?
Dr. Terrio, this is Sheila Schuster. With the racial disparity between the Black moms and the white moms, I'm a little surprised that that's not listed as a key finding.
Well, I guess it is. It's not different from the other years, unfortunately. And it is a key finding, like you said, that we didn't mention. The other interesting thing is when I look at those deaths, few of them might be overdose deaths, but those deaths are not related to substance use. Usually those deaths are related to a medical reason, like a hemorrhage or a cardiovascular reason, a pregnancy-related death.
I think that is key to point out, because I think people that are just going on whim or prejudice or whatever would associate perhaps Black deaths with substance use disorders. And
You're right.
I really think that that's important to point out when we discuss this data. I mean, I think we need to keep focusing on the racial disparity. And I will tell you from presenting in the legislature that legislators are having a hard time hearing that there is a racial disparity. So the more that we can delve into that and point out the things that it's not related to, I think is really, really important. So I ask you to consider that.
Thank you. I will. That's a very good point.
Thank you very much.
Any questions? Any other questions? Okay, so our next update on maternal child will be in 6 months. And Dr. Terrio, would you, when you do that report, could you point out that or pull out that data about the reason for the mortality, increased mortality with the Black women versus the white women, and maybe we need to look at Hispanic women as well, and see if there's a difference there, and look at the causes of the deaths, not just say that it's not related to substance abuse, but maybe we need to start looking at some of the other reasons so that we can zero in on what we can do to help prevent that. I'm not sure if Dr. Terrio heard that.
I did. I'm sorry. I didn't realize I was on mute. But I said that was a great idea. I've written it down. Thank you.
Okay, I look forward to hearing that in 6 months. Okay, any other questions? Thank you very much. As always, your presentations are very informative and helpful, and I appreciate it. Okay, Commissioner, you're up next.
Good morning. A couple updates. I know that many of you may have seen the press release that went out related to our mobile crisis state plan amendment being approved. We have an implementation time of September 1 of 2023. Leslie Hoffman and her behavioral health team have worked very hard on the behavioral health mobile crisis state plan amendment. And I know that we have an aggressive agenda for the next MAC to include the workforce development report. But I think we definitely would be beneficial to have Leslie or her team on the meeting next time to just give you an update on the mobile crisis and go over some of the provisions that are outlined in the state plan. Earlier this week, we also submitted, or last week, July 14th, as part of a Emergency Medical Transportation Task Force. We submitted a state plan amendment that contains provisions in there for ambulances or EMTs, providers to treat in place. Currently, our ambulance transportation reg only allows an emergency ambulance to transport to a hospital. So we're following along the lines of other states who have submitted state plan amendments to allow those EMT providers to come and treat an individual in place without transport. Again, currently those providers do not receive reimbursement if they don't transport. So we believe that may help get some of those services that individuals need and prevent get the services they need in that location rather than transporting them unnecessarily to a hospital. We are also looking at CMS to help us with, we have created a state plan for triage and transport of individuals. So this means that an EMT could go to, or an ambulance could go to a site of a 911 call, for example, assess the situation, treat the individual in place, triage them, and transport them to a location other than a hospital. Those locations could include actually a physician's office. It could include an urgent treatment center, for example, so that individual can get the most appropriate care. Now, this would not be a replacement for a non-emergency medical transportation benefit that we have in place already. And these transportation state plan amendments are designed to work in conjunction with our mobile crisis state plan amendment, because the mobile crisis state plan amendment does have a provision in there that allows two providers to go to a site, and then one of those individuals has to be a behavioral health specialist. So we believe that this will these SPAs in combination will definitely allow greater flexibility with transportation needs for our members. Again, we have just submitted those two, that state plan to allow treat in place and triage and transport. We are definitely have some priorities in the department, as you heard with Dr. Wright's conversation that he had with Pam and I related to PDS and certain things in the HCBS waivers. We still have a large focus on our HCBS waivers. As some of you may know, we do currently have a waiting list in our HCB waiver program, which we have never had before. The good news is that waiver renewal year starts on August 1st. So we do believe that we have enough slots to clear up that waiting list from the HCB waiver. However, we do anticipate that we may have another waiting list as we move forward. So again, a lot of focus on our HCBS programs. The other main focus, a lot of our work has been related to unwinding from the public health emergency. And we have Veronica, I think Deputy Commissioner Veronica Cecil is on the call, and she can give you an update about where we are with unwinding. Veronica?
Thank you, Commissioner. Good morning, everyone. I'm going to share my screen, and we will provide these slides after the meeting to all the MAC and Tech meeting members, and then it will also be uploaded to the MAC website for anyone else that would like to see them. So really just, I'm really going to try to do my best to be quick through all this, but just a snapshot of what the enrollment is looking like. We were originally doing a graph that showed pre-pandemic, but it's getting too big and too weedy. So this is looking at from January of 2022. You will see that there is a dip. Medicaid renewals that were subject to redetermination started in May. So that's why you're seeing a bit of decline. Our current enrollment as of the date of July 3rd, which is the data metric that was used for this, was 1,642,210. So that is below the, we were over a little over 1.7 million prior to the start of redeterminations. We have 4 cohorts going on right now. So 4 months of redeterminations that are somewhere in the pipeline. So our May redeterminations, even though we started those initiated those in early April, we're continuing to show data on them. And the reason for that is because we do have, members do have the capability to request reinstatement within 90 days of their termination. So for May, that would have been May 31st. So if somebody just missed a notice and then discovers walking into a provider's office that they no longer have coverage, they can still provide information to us, and we will retro that coverage back as if no gap. So keep in mind, providers, we are asking for you all to help us connect those members to support and resources to complete that application or that redetermination. So the numbers you will see will change in May. The numbers have, increased for approvals and or terminations as a result of people coming back in and completing those redetermination if they've received a notice. We did extend a group of individuals. You'll see there on the left side, 6,669 were extended. We did that. CMS is allowing states to extend members to conduct additional outreach if they've not responded to a notice. We're doing this specifically for our long-term care and waiver providers, are really vulnerable individuals of our program, to make sure that they do have the opportunity to complete that redetermination and not be procedurally terminated as a result of not responding. So we have asked CMS and have received approval for Kentucky to be able to do an additional 60 days if needed to provide that additional outreach. So of those that we extended for May, 4,100 have been processed. So they might fall under approval or the termination bucket, depending on how the redetermination was completed. We did extend, so the original extension for these members were to June, and we did extend another 2,500 through July. The difficulty here, and certainly a priority for us, is to make sure that all those folks have responded to that notice, because we cannot extend them beyond the end of July. So we are prioritizing those individuals. We're working with facilities and case managers to make sure that that individual understands that they need to take action and submits that notice. The pending bucket is really those folks who had a task when May 31st came, that there was a task pending. And so those are also prioritized so we can make sure we can complete that redetermination. We still have 85 left over from May. But we're tracking, I mentioned the reinstatements, and the good news is that we have been able to reinstate. So in the approval bucket is around 3,500, a little over 3,500 individuals. So it just shows that people are coming back in, and that's a good thing. Here is June, similar. I'm not going to go through all of the specific data points because you all can have this. But starting to again see, we extended. Just wanted to point out we did extend additional folks that had a June 30th end date, so that we could continue to outreach to them and work with them to get that redetermination response in. We do have pending 1,396 from the June renewal. Those tasks are being worked as quickly as possible. Sometimes those do result in an additional request for information that has to be issued, because once the worker starts completing the redetermination, there's information missing. So an RFI might still go back out, but those are still being worked. And again, just from the June renewals, we've got a little over 1,400 that have been able to be reinstated because they did, after their termination date, did come back in and provide the information that we needed. Oops, sorry. So July and August, these look a little different because they're still in process. July 31st is approaching, and so July renewals, we are working We had a larger amount of passive cases, and about 60% of those we were able to redetermine automatically, so that member did not have to take any action to get redetermined for Medicaid. Of the active renewals, so they did have to respond to a notice. Of those, we've had a little over 3,500 that have turned in their information, and we've determined 2,600 of those as eligible and 646 as ineligible. That's an actual determination of ineligibility. We are tracking the number of individuals who are also eligible for a qualified health plan, and that advanced premium tax credit, which, as you all may remember, allows that qualified health plan premium to be really affordable, in some cases at zero cost. We're tracking that because we want to make sure that there's no gap in an individual's coverage. If they're ending Medicaid, we want them to immediately be able to access coverage through the qualified health plan. So we're tracking these individuals to ensure that they are making that connection and they're signing up. For August, again, you will see a large number of cases that qualified, or a larger percentage of cases that qualified for passive. That's always great. And in that, we almost had 70% that were automatically redetermined. So that number is coming up, which is always great, because that means people don't have to take action. But we've got 367 active renewals that have been completed for August, 241 determined eligible, 89 determined ineligible. So continue to work on those cases as well. Just a reminder, this is the rest of the unwinding period. So we've already sent out, I'm sorry, we're about to, in the beginning of August, we'll be sending out notices for September renewals, but here is the distribution for the rest of the unwinding. Keep in mind, and I mentioned this in May, that we did push a lot of cases that have children to later in the unwinding period, because we are implementing continuous coverage for children, and that system, automated system, change, it doesn't go into effect until September. So we wanted to make sure that if a child is determined eligible, they're granted that 12 months continuous coverage. For any child that comes in, though, between April and when the system goes into effect, does still get that continuous coverage. It's just more of a manual process. Wanted to show, because qualified health plan coverage is also very important as we go through unwinding. So this is a snapshot of what that enrollment looks like. We're, always happy to see it tick up, because that means people are moving off of Medicaid who've been determined ineligible and accessing that coverage. Just also wanted to remind you that we've talked about this before, but the Office of Civil Rights, when it comes to telehealth, is requiring providers to return to HIPAA compliant platforms. That due date is coming up August 9th. So this is just a reminder to make sure that if you're doing telehealth, you have to be in compliance with a HIPAA compliant platform. Continue to always advocate to please sign up for one of our social media accounts, like us or follow us, because it is the best way to stay up to date on the most current information on unwinding, get information out when we hear scams or trends. We do have the monthly stakeholder meeting. All of those meetings are recorded and posted, including the presentations on our unwinding website. We just had this month, a specific stakeholder meeting for the 1915C waiver members and providers. That information is out there. So if you you were not able to join that, I encourage waiver providers to go out and access that and watch it and look at the presentation on at your convenience. It provides a lot of really good information. And then, we're striving to keep providers in the loop. The CLOCS report, the Kentucky Level of Care report, that's accessible by our long-term care and waiver providers. It allows them to identify the members that are subject to a redetermination. And then in Kentucky Health Net, don't forget, providers, you can see that redetermination date. So as the member comes into your office, if it's a date that has passed and they've lost coverage, definitely connect them so that we can make sure that loss of coverage, that they were actually ineligible, and then connect them to a qualified health plan if that's the case. Or if it's in the month or the next month, just ask them if they check to see if they have a notice or have received a notice from Medicaid. So that's the end. Happy to take any questions that someone might have about unwinding. And Dr. Schuster, I see you trying to raise your finger.
I have never figured out how to raise my hand on these Zoom things.
It's okay. You can see fingers.
Thank you very much, Veronica. It's always good information. I'm curious, under your terminated, there was a category that was actually the largest percentage, and it said procedural reasons.
Yes.
So they are not ineligible. So what's a procedural reason? Can you give us an idea?
Yeah, honestly, the biggest portion of that is they did not respond to a notice.
Okay.
And that's been challenging, not just for Kentucky, but across the United States, for state Medicaid agencies to get folks to actually respond to the notice. So a determination can be made based on the information that relates to that case. So, we've been doing tons of outreach. So by the time that somebody's renewal end date comes up, they've heard from us. We have outreach both when the notice goes out, then a couple of weeks later, and then on the 15th of the month. I'm going to turn off my video because I'm having trouble. Then on the 15th of the month of their renewal, if we've not received anything from them, they get another call. And then the managed care organizations separately are also outreaching to their members. So we really have tried to exhaust all outreach efforts, but we're still learning and thinking of new opportunities to do that. And for instance, with back to school, we've got some plans on how to get information to families through back to school efforts. So the biggest challenge really has been just encouraging someone to return the notice, even if they think they're no longer eligible. We'd still like to be able to make that full redetermination. But I think most folks, when they get it, may think they're not eligible because they do. I mean, some do know their income is above the Medicaid federal poverty level, so they're not even responding.
Okay, thank you. I wondered if that's what it was, because that's been the biggest bugaboo, I think. Because everybody trying to figure out with multiple contacts why people are not responding. So thank you very much, Veronica.
You're welcome. Nina, I think I saw your hand next.
Yes, I just want to make sure that I'm clear on what non-HIPAA compliant platforms are excluded. So obviously FaceTime, but what else? Anything else?
So I do want to, of course, as an attorney, disclose that I am not the expert on HIPAA compliant platforms, but I would say, so yes, FaceTime, our understanding. Gosh, apologize, I'm blanking on. There is one other that I know.
Facebook Messenger.
Thank you, Dr. Yeah,
Okay.
Facebook Messenger is another one. Now,
Okay.
I highly recommend, because there's been acknowledgement by a lot of the non-HIPAA compliant platforms of the issue, and I think are trying to find ways to become HIPAA compliant. So definitely check in with those platforms directly to see if they put things in place to make them HIPAA compliant.
Thank you.
Doxy.com is compliant free. So I'm not advertising or anything, but that's one option.
What is it?
Doxy.me.
Doxy.me.
It's DOXY.me. M-E.
Okay, thank you.
Dr. Bobrowski has his hand raised.
Yes.
Yeah, question on and I don't know if this is an unforeseen problem or not, but just with the unwinding, some of our procedures in the expansion codes are multi-appointment procedures, like making a denture, doing a root canal on an infected tooth. Of course, dentists don't get paid until the procedure is complete, but we're getting some calls on folks that are have been unwound and no longer, they got the procedure started, but now they are no longer eligible for Medicaid, leaving the dentist stuck with, well, what do we do? Are they supposed to go back now and charge the patient, or because they already have pay expenses, from lab supplies, office supplies, time, paying for staff, and the critical thing is that technically we're not supposed to bill it until it's finished. So I don't know, have you all talked about that or looked at that?
We have, Dr. Bobrowski, and thank you for bringing that up. We in fact have a meeting this afternoon with the managed care organization leadership, and this is an agenda item. We do want to provide guidance to providers. I think it is certainly our intent not to disrupt a service that's been initiated, and especially, dentures, and we know there's a whole host of services that require that multi-appointment modality. So we are discussing it and do plan to issue guidance so that you all have that available to you to rely on. You're welcome.
Thank you.
Any other questions? Okay, thank you.
Thank you, Veronica. Commissioner, would you send me an email with for the agenda item for the mobile crisis health plan? I was trying to take notes on what that was, but I couldn't write fast enough. And if you could just send me what
Yes.
that item will be, I'll put it on the agenda for the next meeting.
Yes, we will send that to you, Dr. Parton.
Thank you. Okay. Next up are the reports from the MCOs. And I would like to say that we've got about, well, we're going to run short on time, I think. So I'm just kind of letting everybody know that we'll do the best we can to end up on time, but we might run over just a little bit, because I want to make sure that everybody gets the information that they need and is able to ask questions. Okay, so next up is reports from the MCO, and Aetna and WellCare are going to report today. Aetna, why don't you go ahead and go first?
Great, thank you. Can everyone hear us okay and see our screen? Lauren, I think it looks good from my vantage point.
Yes.
Okay,
Looks
great.
good.
We will jump in. My name is Paige Mankiewicz. I'm the market president for Aetna Better Health of Kentucky. I have Dr. Madeline Main here with me today. She is our regional CMO. We have a very extensive deck, and to your point, Dr. Parton, we do not have time to go through all of it. So we are going to stick to our 10 to 15 minutes, leave a little bit of time for questions. At the end, please feel free to ask us questions. And we did provide our email addresses here on the screen. So if you don't have an opportunity to get a question in, or if you spend some time looking through our deck, they will be made public. I believe they will be on the MAC's website. You can, take a look through there. And if you have questions, please feel free to send us an email. And we would be happy to engage further based on the information that we have in the deck and what we talk about today. So moving on into our presentation, we wanted to start by showing what the top areas of priority were that we set for 2023. So my team met in the fall of 2022, had a very intentional strategic planning session, and really decided that the areas of specific focus based on data that we had and what we know is incredibly important. So I'm going to hit on a couple of these. Dr. Main's presentation will take us through the last three, but I'm going to start by addressing member engagement. So we know that engaging with a Medicaid membership and doing that in a manner that is successful doesn't always look exactly like what you might expect. Traditional methods of outreach, sometimes mailing, things like that, is not how we're able to actually reach our members in a meaningful fashion. So we're utilizing other methods of outreach, text messaging, really focusing on when a member calls in, or if we're at an event and we see one of our members and talk with them, that we're updating their telephone numbers. We've got email addresses, things like that, because we know that that's how members engage better with their healthcare company. We also know that engaging community partners who are neighbors of our members is a really important way to make sure that we are locating our members, we are engaging with them, we know how to get in touch with them. We know that that's especially important, and the Deputy Commissioner hit on that during this unwinding period. It's incredibly important that we know how to get information in front of our members to ensure that they maintain their eligibility, and then also that they're able to access services that they need to be able to access. As you can see from this slide, our membership is pretty evenly distributed across the regions, also fairly evenly distributed by gender and by age group, as far as adults and children. We have approximately 250,000 members, 30,000 of which are with our SKY program, which we'll flip to the next slide, if you will, Lauren, and we'll hit on SKY just briefly. We spoke last year to this group at length about SKY, and so I'm going to move over it pretty quickly, but I don't want that to imply that it's not an incredibly important part of our health plan. It absolutely is. For those who may be unfamiliar, SKY is our sole source contract where we provide the Medicaid coverage for all children in Kentucky who are system involved. So if they are in foster care, if they are in juvenile justice custody, if they have been adopted from foster care, or if they've aged out of the foster care system but are still under the age of 26. SKY is a high-touch care management model with other ancillary services such as a training collaborative, a lot of behavioral health services, a lot of interaction with the state. Dr. Main is going to get into some of the outcomes that we've had with SKY that we are incredibly proud of. And then Dr. Main will also get into more specifics with actual health outcomes, but health outcomes are a huge part of our priority area and will continue, obviously, to be, as we set our strategy for 2024. We're particularly focused on members with SUD, maternal and child health care, getting kiddos caught up on vaccinations and well adult exams, and identifying and resolving social need barriers. But we also know that in order to have good health outcomes, members have to have appropriate and adequate access to care. And I know that we have an adequate network, but oftentimes what appears on paper or on reports may not tell the reality of the situation. So because of that, we are very engaged with our network of all provider types, making sure that we have appropriate coverage of providers in all areas, all specialties, PCPs and beyond, statewide. One area of focus that we have that I know is of great importance to this TAC and great importance to us as a health plan is making sure that we are engaged meaningfully with our dental network, and that we are growing our dental network, and that we're addressing the needs and the concerns of providers there so that our members have timely and appropriate access to dental care. So with that, I'm going to turn it over to Dr. Main.
Thanks, Paige. Good morning, everyone. I'm going to get into now, a lot of our programming around physical and social determinants of health and kind of how we think about what we're doing and how it affects our membership and what we're looking for outcomes. So along with, our standard suite of services that includes care management and behavioral health services, we really do try to look at health equity and social determinants of health, women's health, behavioral health, kind of make them into separate populations that can mix together, but that we have programs and strategies to identify the needs for these populations. Next slide, please. So when we talk about social determinants of health, what we're really talking about is getting resources and solutions to members that have issues with food, transportation, security that may take precedent over them seeking medical care. And so resolving social determinants of health resolution issues really do then help to reduce in kind of low value care around admissions and emergency rooms. So when we talk about what we do, we have gift cards, we have meals delivered, and those solutions then therefore take people back into their homes. They take them back to their outpatient services and away from the unnecessary utilization. Next slide. Here's a long laundry list of all the things that we do around social determinants of health and where we are. But things I wanted to call out were our community investments around housing, our GED certification, our over-the-counter medication benefit, which all our members get, along with additional benefit for period necessities to help with that health equity issue. And then we do work with a vendor around loneliness and isolation to identify members who may not come up on a claim, but have other issues that we can help resolve, which is finding them and knowing what their issues are to get there first. Next slide, please. Focusing on women's health, the main issue here that we really look at for our members is to drive them into high value care in their primary care offices to get those screenings for cancer care screenings as well as obstetrical care. And our goal is to not just get them into the office, but to have that continuum of care even after delivery for a pregnant person. You can see that 182 perinatal and postpartum assessments were completed by care management for Q1 2023. And those engaged in care management have a higher percentage of delivering after 37 weeks than those that are not. Additionally, our focus with text reminders has increased our mammogram and our pap smear rates, which continues to be on a positive trend. Next slide. So lots of data, just trying to hit the highlights here because I know that we're running short on time. I know, across the country, behavioral health has really been a focus, especially coming out of the pandemic and the rise in anxiety and depression that we've seen. And certainly that's not an isolated incident for Kentucky. So we have a lot focused on behavioral health, including our behavioral change education, our behavioral health crisis line. And then we also have a focus on SUD prevention and access to MAT therapy. So you can see that over 8,000 members have been outreached to educate around opioid prevention. That has also increased our usage of MAT. Next slide. Focus on chronic condition management is certainly always one of our focuses. It's never changed. These are our HEDIS metrics. These are how we care for our members and making sure that once a member has been diagnosed with a chronic disease, that they're maintaining the standard of care that is acceptable for those conditions. And you can see that through additional programming around screening reminders, free blood pressure cuffs, and remote patient monitoring, we've been able to increase all of these metrics related to chronic conditions, including blood pressure control rates, hemoglobin A1C testing, as well as diabetes testing rates. Next slide. Population health and prevention wellness is also kind of the other end of our spectrum, where we have chronic disease and then the prevention. And typically, we do a very good job about prevention and focus on children and getting them into well checks, but recognizing that adults, need these preventative measures as well to prevent those chronic diseases through our HRAs, our digital campaigns, and our additional text messages, as well as our community outreach programs and our member advisory committees. We do have an increase in annual well visits for both children and adults. Next slide. So what does this all mean? We have lots of programs, good results, everything's trending up, but does it make a difference? And you can see here that 92% of our members are satisfied with our PHM programs, as well as 82%, which I think is an astounding number, have made changes in how member cares for themselves since starting and being involved in one of our programs. The next two slides are very busy, and I'm not going to bemoan the great work that we've done, but you can see just from a visual that all of our outcomes are trending positive. So coming out of the pandemic, recognizing that we need to have extra effort, extra programs, extra ways that, that people are engaging in their healthcare through their phones, through remote patient monitoring, through texting. You can see that we have positive trends for our HEDIS My 2022, both in our health plan, and then the next slide will show you the positive trends that we have for our SKY program. All this in all says that, we are a 3.5-star rated program, and we look forward to our future years to continuing those upward trends. This is all very, I think the next slides are kind of standardized. Some of the other presenters will probably have similar slides, and so I won't, kind of go into a lot of that data that's to come. But I did want to focus on this slide to say, in the last few years, we've seen an increase in the amount of authorizations that have been requested, but our denial rate has stayed somewhat stable. So that just means that we are getting more authorizations and approving more services for the members in Kentucky. A list of, why prior authorizations may be denied. I know this is always a contentious issue, and, things do get denied. That is part of the managed care process. And really, the main reason for denials are lack of medical necessity. We decide as an organization how to authorize, what needs an authorization. We look at low value care, we look at expensive care, we look at care that has a lot of potential risks involved to assure that those members that are needing the services are the ones that are actually getting the services, and that they are being performed by providers that are credentialed and have quality outcomes related to those services. So, a denial is not always an easy thing to receive, but there is, evidence supporting that, and we do follow our criteria in order to make those determinations. A lot of these denials too, when there's lack of information or, there's an opportunity to have a discussion with peer-to-peers, they can be turned over, whether on a peer-to-peer or in appeal. So there's always that opportunity. Next slide. So the next 4 slides really are just the diagnosis and trends around behavioral health, physical health, ED, and inpatient utilization. We can kind of just flip through these slides quite quickly because of time, knowing that, what we're really seeing, and I just want to stop here, is this behavioral health inpatient trend. We're really monitoring this. This again is a trend across the country, recognizing that people are having a lot of behavioral health. There is an increase in predominance and prevalence of the behavioral health issues, but I think also the pandemic has allowed us to have greater access, right? So we're accessing, and members are accessing care that they normally wouldn't with, like I said, with digital, with phones, with our behavioral health crisis lines, with the mobile crisis implementation that's, going to be occurring in the fall. So while this trend may be going up, I think that it's a trend that is new to us because of all the increased services and opportunities to engage with those services. These are just the physical health inpatient, and I'll stop here real quick, the readmissions. We can see the readmission trends are pretty stable throughout the years, both for behavioral health and physical health. And, that is something that we're always working on with all these programs, with the increase in network that Paige referred to, with our case management, with, outreaching members for SDOH resolution. So this is something that's always, in the back of our mind. And the last slide that I'll comment on is our primary expenditure for primary drivers of expenditure. And, again, it's the mental health non-inpatient. So that's all those outpatient services. Having people receive those services when they're medically necessary is a good thing. So seeing that volume, again, I think it's just a testament to that we're providing more services and more people are accessing them. But the real story around cost is retail RX. So the number of scripts has increased as well as the cost. And that's the end of our presentation. Very quick, I know, trying to be cognizant of the time. So we'll take any questions. I'm happy to have this opportunity to present. Thank you so much.
I see your hand there. Yes, thank you. Thank you so much for your presentation. Under the prior authorization issue, I was pleased to see that the number of denials was staying flat relatively. But I did note that the slide showed that the total requirements for prior authorizations are on a real upward trend. And it's concerning at a time that it requires additional burden of providers when there's such a workforce shortage. So just a comment.
Sure, and I appreciate that, and I thought that might come up, and I can actually explain, I think, that a little bit more specifically. So, in 2020 and 2021, we had a relaxation of prior authorization. So I think what you're seeing in that uptick is as things were able to be turned back on for prior authorization, there was a natural increase. We also had an increase in membership. Because of the public health emergency and members not going through redetermination. So we've got a bigger pool of members that were subject to or receiving treatment that might require prior authorization. But to your point, we do have a steering committee that pays attention to the number of services that we're, having very high approval rates on prior authorization to say, do we really need to have a prior authorization on that? And we will remove prior authorization. So that work is ongoing on a regular basis. It's not an annual review, it's a quarterly review, I believe. So I think there's several factors that are playing into that increase, but your point is well taken.
In fact, if we work with providers around prior authorization and removing prior authorizations, in fact, right now we're working on, with a provider that didn't see the necessity for a 90-day, for a 60-day, but needed 90 days. So we looked at what are denial rates for the provider, what are the denial rates for the procedure, and, changed that requirement to make it the 90 days instead of the 60 days. So it is a collaboration, but again, just to stress the point of, making sure that our members are getting evidenced care and that not wanting people to undergo services, procedures when they aren't evidence-based is kind of, and making sure that quality outcomes are happening are our primary focus.
Thank you for your ongoing attention to this matter.
Yeah, your point about PAs being retracted, requirement being retracted and then re-implemented is noted. A more detailed PA, breakdown maybe beyond the scope of this presentation. Looking at how many of your codes require PAs over a period of years is something that Beth, we may look at when we set forth the criteria for the MCO presentations. That may be something to look at next year. Is the number of codes that require PA over time. Your denial rate stays pretty consistent, but it is concerning with the at the comment that was made. If you're denying the same amount, but you're requiring a significantly increased number of PAs, and again, these numbers are a bit skewed because coming out of COVID, but I can tell you that is one of the greatest obstacles that my colleagues have with seeing Medicaid patients, either enrolling in Medicaid to begin with or in capping the number of Medicaid patients that they see. The reimbursement rates are what they are. We all have a program that we're working within, but when it requires a significantly increased administrative burden or profound amounts of bundling within groups of procedures performed at the same day, or PAs for things that that are just not that historically haven't required PAs. No, yeah, I do appreciate the fact that you're looking at evidence-based care. That's great. The transparency on why an item or service was required now requires a PA would probably help it go over a little bit better with physicians, but that would also provide an opportunity to say, okay, look, well, here is the evidence. Let's remove the PA if we can find an evidence-based consensus. But that's my comment.
Thank you.
Any other questions? Okay, I had a couple questions. One, where you listed the primary care providers at the very beginning, you listed physicians. You did not list nurse practitioners or certified nurse midwives. Are they included in that physician count, or did you just leave them out?
We have a lot of additional information in the appendix. I'm looking at it right now. So participating providers by region, we do have physicians and nurse practitioners listed on page 34 of our deck. So it's in the appendix. I do not see that we have nurse midwives on here. I may be speaking out of turn, so I apologize, and I will go correct myself if I am. I'm not sure if that's, I apologize. I don't know if that's Medicaid covered service at this very moment, but I will take that back and double check.
It is.
Okay.
Nurse midwives are services are covered. Okay, so
we can supplement with that.
okay. And then my next question is related to the, oh, sorry about my dog. Related to the gift cards. Do the recipients or the participants automatically receive the gift card? For instance, if they had a hemoglobin A1C, you know that because of the lab billing. So do they just automatically receive the gift card? Or do
We have a member of our HEDIS team or a group within our HEDIS team that does outreach the member to confirm where they live, what phone number, what mailing address to send it to, because often the mailing address that we have on file is not where they live anymore. So we do have to validate that with the member. We would love to get to a point where it could be instantaneous, but these often are, whether they're electronic or they're hard copy gift cards, we want to make sure that they're actually making it to the hands of the member.
Okay, but you automatically do that based on the billing codes and that sort of thing.
Yes.
Okay, I just wanted to make sure that the provider didn't have to do something.
No.
Okay, that's the only questions I had. Thank you.
Okay, thank you.
Anything else? Okay, I would just like to add that because there is so much information here, probably members of the MAC will want to look at these presentations. And so I'll add to the agenda for the next meeting that if people have questions after they've looked at it, they can ask questions to each of the MCOs at the next meeting. So you may or may not receive questions at the September meeting.
We will be prepared.
We love it.
Yeah.
Thank you. Okay.
Thank you.
Next up is WellCare.
Okay, good morning. Corey Ewing, Plan President here at WellCare. Just wanted to say thanks for the opportunity to present to you guys today. I'll be pretty brief in my comments and we'll toss it over to my team and let them get into the meat of the deck. But a little bit about WellCare. Most of you know who we are, but we've been here since day one, 2011, when managed care came to the state. We're fortunate to currently hold the largest market share in the Medicaid space with 32% of the market share, with primarily the majority of our members being in regions 7 and 8. We see quite a bit of acuity coming out of that region. And the reason I point that out is you'll get to hear a little bit about the work we're doing around social determinants of health, because it's a lot of those things that lead to those higher acuities. But you'll get to hear the team speak to that in great depth here shortly. With that, I will toss it over to Mark Niarco. He's our Chief Operating Officer. So I will let Mark go.
Hey, thanks, Corey.
Oh,
Thanks, Corey.
Okay, there we go.
All right, awesome. So we built a robust provider network to support our membership base, and we've met accessibility standards for all provider categories. Thinking about the accessibility standards, we're supposed to, and for urban members, one provider within 30 miles, and for rural members, provide one provider within 50 miles. We are 100% adequate for 33 of 37 categories, and our lowest rating is 95% for endocrinologists. We continue to assess our network adequacy, looking for potential gaps. We also have a comprehensive review on a quarterly basis where we're looking at our network. And when we identify potential shortages, we launch a targeted recruitment initiative. Example of that is with applied behavioral analysts. 2020, we realized we had a gap and we launched recruitment then. We went from 74 ABAs to 225, and we're currently 100% adequate for that. In addition to that, when members are in network, when an in-network provider is unavailable, and a member needs an out-of-network provider, we're very quick to negotiate with that provider, and we can engage with a single case agreement within 8 to 24 hours. Next slide. This slide outlines the out-of-network requests that we received in 2022 by quarter. The majority of the out-of-network scenarios, the member was out of state. And so that's when we would engage with those providers to do a single case agreement. And we do take a look at patterns in our out-of-network claims and utilization, and we'll reach out to negotiate with a provider with a network agreement if we feel like there's an opportunity there. Telehealth is a very important tool that we use to ensure access. We've actually paid claims to over 12,000 distinct provider IDs and 89 unique provider types. Looking at the graph on the left, you'll see our spending from 2020 to current has been very robust. Now I'd like to turn it over to Paula McFall, who our Senior Director of Behavioral Services. Paula.
I'm on mute. I'm sorry. I'm here to talk about our primary drivers for spend, and much of it is behavioral health. So just giving you some information on that. Of course, the trend began during the pandemic and it continues. Overall behavioral health per member per month spend rose 12.8% in calendar year 2022 compared to 2021. Lower level, including non-BH services, are key drivers here. Data shows that there are some members that only receive BH services that are peer support or community support rather than clinically based treatment by a licensed provider. So here's two examples of peer support. PMPM rose 135% from 2019 to first quarter of 2023. And the units per 1,000 also surged to 198%. Prior to that, in 2020, peer support was our 11th PMPM ranking, and now it's 4th. Community support services rose 114% in the same time period, and also jumped per K, units per K, 115% over time. And community support was 16th in 2020 for PMPM ranking, and now they're 6th. Next slide. A couple more examples. Therapeutic behavioral health, the PMPM jumped 213% during that same time frame, as did the units per 1,000. And psychoeducation units per 1,000 jumped 222% from 2019. Next slide, please. This is a slide that compares a couple other states that Centene have a Medicaid business, Ohio and Indiana. And it looks at community-based services, which includes your peer support, comprehensive community support, and then your outpatient services, which is provided by a licensed clinician or physician, nurse practitioner. So Kentucky has 37% fewer members per 1,000 of community-based services than Ohio, but they are 125% higher in units per utilizing member. Similarly, the units per 1,000 for members in Kentucky are 43% higher than Ohio for the community-based services, despite 37% fewer members per 1,000. And as you can see from these slides, in contrast, we are much lower for outpatient clinical services than Ohio, and a little bit lower than Indiana there. On the on the table to the right, for 2021 to 2022, we had a 24% increase in PMPM for community-based services. Units per thousand were 11.6 increase. Units per utilizing member were 26.6% increase, and then units per K were a 41.3% increase. So just showing trends. This is the last slide. We just wanted to show a couple more examples of the trend going up. For partial hospitalization, our PMPM has gone up from 21 to 22, 42%. Users per K, 21.5%. Units per utilizing member, 30%, and units per thousand, 58%. Also applied behavioral analysis, which we expected to increase since we did increase our provider providers across the state. So this is actually a trend we wanted to see. The PMPM is 56.5% increase, users per K, 59.2% increase. The utilizing members decreased very small, 1.2%. And then units per K increased 57.3%. And I will now have Dr. Patel talk to you about denials and approvals.
Thank you, Paula.
Yep.
So our goal for selecting services for prior authorization is to ensure that the members get access to the most appropriate clinical care. And so we want to have member-centric care. And for example, pre-pandemic, before PA was suspended, BH providers would often submit authorization requests for pediatric members, but then subsequently call our medical affairs team, which we do have some child psychiatrists on board, for the best advice of what the next best clinical service should be. Should it be psychotherapy? Should it be ABA? Or should it be, short duration of stimulant? And so what I'd like to say to that is there's a broad spectrum of inputs when a PA is determined, chiefly driven by clinicians who are regularly reviewing the published evidence-based literature and guidelines, along with support from data analytics, certified coders, and with a broad review for fraud, waste, and abuse. Next slide, please. And so as you can see here, our service categories for top 10 authorizations by volume for 22, most of our things are fully approved, greater than 90%, with the lowest being radiology and consultation and treatment. The top denial reason, similar to the previous MCO, is medical necessity, and then a distant second is denied for no prior authorization. And so typically the most common reason is there's not enough information in the prior authorization. And we understand it's a delicate balance of reducing the burden on the provider and encouraging expeditious care in an evidence-based fashion for our members. It's a dance. Next slide, please. And so what we will say about ER utilization with physical health and behavioral health is top 10 diagnosis, upper respiratory infection as number 1, along with cardiac chest pain and other chest pain. COVID-19 has fallen down, but it's still on the list. And then you will see things that are not surprising to you, but you will see distinct BH ER claims is increasing year over year, from 332,000 back in 2020 up to 359,000 and change in 2022. And physical medicine ER claims from 344,000 to 370,000 as well. And we also acknowledge as the pandemic has subsided and utilization is increasing as people are looking to get the care that may have been avoided in that time. Some of this is expected, but I do think some of it is unexpected. Next slide, please. With that ER utilization in mind, what we do know is when we are able to have members who have not churned out, or members who are not suffering redetermination, members who we can continuously have enrolled in our plan for at least 6 years, which is 156,000 and change members, you will see that our ER visits for that cohort has extensively fallen from 2017 to 2022. I'd like to highlight that number from 128,000 and change to 90,000. But the number that I would like to highlight the most is our ratio of PCP visits to ER visits increasing. So for that cohort, we are able to connect those members all the way to their primary care physician at a larger range. And that's because we have care managers who establish relationships. We have an analytics team who has an immense amount of ability to do prioritization and quality work. We do understand that there's a balance between using technology and using a warm handoff and warm touch. As Corey had mentioned, our members out in Eastern Kentucky, they're not always adept to using high tech applications. And so we do use a balance of both. And I think it's necessary to have multiple tools in our toolkit. Next slide, please. And we also let data drive our care management initiatives that we do. We don't have any pet projects. And what we do talk about is food. Food insecurity is a big issue. We believe that food insecurity, without having consistent food, the correct food, and food for your family, can result in other SDOHs being exacerbated, augmented, and decrease in the management of chronic conditions. And so we have a program with Good Measures that is quite vast and deep. And you will see the tremendous amount of results here. Inpatient visits per thousand, less than 21%, decreased by 21%, non-ER inpatient by 7%, and total medical per member per month spend by 6%. How do we drive this outcome? We continually assess the initiative. Our data and analytics team has developed a Kentucky market tool for Kentucky members alone. We don't use a corporate tool. We don't use a United States tool. We use a Kentucky created and Kentucky based tool because we're serving Kentucky members. Next slide, please. And something that's near and dear to our heart is substance use disorder and how we can combat that. We have an opioid task force that was started back in 2021. As I've alluded to, we use data to drive our decision-making along with our care management team, which is out in the field, along with the experts of our pharmacy team. What we have seen is 68% of our members taking an opioid disorder medication have received therapy in conjunction with that medication. And what I'd like to say about that is we encourage and emphasize higher level therapy, clinically appropriate therapy, evidence-based therapy, and appropriate duration of therapy, because all those things matter in terms of decreasing recidivism in substance use disorder. We have a member-facing and a provider-facing report. Percent of members compliant with pharmacotherapy, percentage of members receiving counseling, and prescribed Narcan. Our providers know this for their panel, and we're able to use our care management, our quality teams to help providers reach the appropriate goals to impact our members. Next slide, please. I'd like to pass the deck over to our Senior Director of Member Experience, Darren Levitz.
Thank you, Dr. Patel. To carry on what you said, at WellCare, we rely on data rather than hunches to drive our community involvement. While any social determinant program has its merits, it's essential to ask if it's the most relevant to the needs of the community. WellCare's process incorporates multiple publicly available data resources, as well as our own proprietary data to calculate with precision the most consequential needs of each of Kentucky's 120 counties. For example, we include data from the Social Vulnerability Index to help identify each community's susceptibility to adverse impacts of natural hazards, including disproportionate death, injury, or loss of livelihood. We look at other resources such as the Rural Health Hub to assess where food deserts are or where there may be limits on provider types such as dentists. Another source of data is a compilation of requests we receive from our Community Connections Helpline, a free resource available to all Kentuckians. Using the CCHL's data, we're able to identify thousands of requests we receive and target them to specific cities, counties, and even zip codes. It's through these data sources and more that we create tools such as the map that you see. These maps are provided to WellCare's community engagement team members that live across the state and serve in the communities they each live in. Taking a look at this example, Fulton and Muhlenberg are two counties at the highest risk for this region. Digging in deeper, the data shows us that the three biggest barriers to care are housing, crime, and environmental conditions. The community engagement coordinator is then given contact info for hyper-local community-based organizations that address those needs. While nobody would turn down a food insecurity program in these counties, based on the data that we see, the best use of resources is to invest in programs like rent assistance, re-entry initiatives, and improving water quality. These analyses are conducted for each of the 8 Medicaid regions in all 120 counties through the state of Kentucky. As mentioned previously, our Community Connections Helpline is a heavily leveraged resource by our members. In a given year, we receive thousands of calls from people in need. We listen to their concerns and dig deeper to find where they may be struggling. Let's face it, when someone is food insecure, they are also likely dealing with other issues like housing instability, or they are in need of utility assistance. In fact, on average, we assess 2.4 needs for each person that calls the CCHL. WellCare does not rely on purchasing data for the CCHL. We've found, especially after COVID, that the CBO info on external resources is out of date, and several CBOs aren't even listed as operating anymore. Instead, the community engagement team is responsible for gathering all federal, state, and local resources. These must be entered and or re-verified throughout the year. Because of this stringent process, we address literally 99% of the caller's needs on the spot. For the 1% that we don't, we take on average just 4 hours, only half a day, to find a viable resource. As a quick aside, our best practice used to be 2 days, but we realized that when people call the CCHL, they aren't calling for rent that's due in 3 weeks or refrigerators that may be empty next month. Their world is on fire, and getting back to them as quickly as possible is critical. There always used to be a supposition that there's an ROI on SDOH programs, but the results have always been tough to quantify, but not now. We not only use our data to help guide our grants, but to demonstrate the value they bring. On this slide, I'll give 3 brief examples. In Bowling Green, we partnered with Hotel Inc., where we provided a grant to help their clients provide safe and stable homes. Based on the data, comparing 6 months prior to the program and 6 months after, we saw a dramatic 67% reduction in inpatient visits, a 100% reduction in readmissions, and a 23% reduction in ER visits. With Welcome House in Northern Kentucky, we help people as they transition from housing uncertainty to housing stability. Again, comparing 6 months data prior to the program and 6 months after, we saw with these members a 43% reduction in inpatient visits and a 33% reduction in ER visits. And lastly, our example with Water to Wine, where we dealt with food insecurity. After our grant, we saw a 50% reduction in inpatient visits and an incredible 61% reduction in ER visits. Being sensitive to time at this point, I'm going to turn this back over to Corey Ewing, our plan president, to wrap up.
The majority of the slides where our deck is, as you can see, we're only about halfway through it, so it'll be available for you guys. I know we're short on time, so we wanted to stop here and see if there are any questions for any one of our presenters today. And again, we appreciate the opportunity to present to you all today.
I have a question and a comment. On one slide on substance use disorder treatment, I was curious because there was 68% of those patients receiving treatment, and I'm assuming that's with buprenorphine. Correct me if I'm wrong on that. We're talking about buprenorphine?
That is correct.
Okay, so both of the Kentucky Board of Nursing and the Kentucky Board of Medical Licensure require counseling as part of treatment with buprenorphine. So I just found it kind of interesting that 68% of members received therapy in conjunction with the medicine. So it's just a comment. And then my question is that, or comment is that, not related to your slides, but that recently Kentucky legislation was passed to allow APRNs to prescribe controlled substances and in the past, non-controlled substances independently after having a collaborative agreement for 4 years. And so there are now many nurse practitioners who do not have a collaborative agreement. And I just got word that a psych mental health practice was hiring a nurse practitioner and wanted to credential with WellCare, and they were not able to credential because they didn't have a collaborative agreement. So I'm wondering if WellCare is going to change their policy on that, since there are going to be many nurse practitioners who no longer have prescribing agreements.
I would love to get the specifics on that one, because I would love to see what happened with that.
Specifics on
of the who actually the case, who it was, the provider was, because that does not sound. I want to make sure that that doesn't sound like it was handled correctly.
Okay, so you do know that there are.
Absolutely.
Okay, that you will credential. Okay, I will get that information to you. Can you send me your so that I can get that information to you?
Absolutely.
Dr. Parton, I just put Stuart Owen. I just put my email in the chat as well.
Okay, so should I email you?
Yes, yes.
Okay,
Thank you.
thank you.
Dr. Bobrowski has his hand raised.
Got a quick question, and this might just be a typo, but I think it was slide 16. What it was in the list there. It listed down rental. Was that supposed to be dental?
Dr. Bobrowski, I think that's DME, durable medical equipment rental items.
Okay. Thank you.
Certainly.
I don't see the in the chat.
Beth, I can get you Stuart's email.
Okay, great. Thank you. Any other questions for WellCare? Okay, thank you guys very much. And I'm sorry that we didn't have time to go through all the slides, because I know there's a lot of valuable information there. So we will be looking at that and maybe have questions at the next meeting.
Okay, thank you.
Thank you. So at the September meeting, Anthem and United will be presenting. So next up, we have reports and recommendations from the TACs. And first up is behavioral health.
I'll go lickety split. Thank you. Sheila Schuster reporting for the TAC. We met on July 13th and had a quorum. We got a report from Ann Holland about the unwinding, and I will tell you, and I want Veronica to know that we made a big pitch with not only our providers, but also with the peer-run, consumer-run centers to get the word out there for people to respond to those inquiries from Medicaid. We did have an issue involving pharmacy that I wanted to bring to everyone's attention because it's troubling. I had gotten an email from someone who used to work at a SUD treatment clinic, and they had gotten a letter from about 7 or 8 pharmacies in Western Kentucky that they were no longer going to fill prescriptions for psychostimulants for any of their clients. A neighboring clinic that does full service behavioral and physical health got the same letter. And it took some time for me to get that information to Medicaid. And I was glad at the BH TAC meeting that Dr. Prather said that it had been taken care of, that they had called the pharmacies and the pharmacies had complained about how the prescriptions were coming in or something like that. And then just had decided that they weren't going to fill the prescriptions. And they apparently are now filling the prescriptions, although I've not heard that confirmed back from the provider organizations. I guess my concern is that's an instance where people were absolutely not getting their prescribed medications. And I heard about it really just via the grapevine. So I don't know what kind of system we need, but we really need to not have that kind of thing happen. And I don't know if pharmacies can just decide willy-nilly. Maybe it's something I need to discuss with the pharmacy TAC, or we need to put on their agenda, but really concerning. We got an update on the 1915I SMI waiver that will have supported housing from Pam Smith, and we're looking for those town hall meetings to take place hopefully in September. We have no new recommendations for the MAC. I want to end on a positive note, and that is to thank all of the MCOs, but particularly Herb Ellis from Humana for working together so well to get a bypass list together for dual eligible Medicaid members who have Medicaid and a commercial insurer. And Herb reported that it's been in effect since May 1st and is working very well, and there are no problems. So we've had that on our agenda for, since we've been in existence, which is about 12 years. Our next meeting is September 14th. Thank you.
Thank you, Sheila.
Sheila, I would like to, this is Kathy, pharmacy up here. Would like to, maybe talk to you offline to find out what in particular was going on there. I mean, you always want to make sure you know what the situation is. And also just, pharmacists do with their professional judgment can, not fill it, but typically it's unusual to see a policy, if it was a policy that's a little bit different. So, but we can talk about that and I'll be happy to, help in any way I can.
Thank you very much, Kathy. I'll reach out to you for sure.
Okay, next up, Children's Health.
Hi, Alicia Watley here from the Children's Health TAC. We did meet earlier this month on July the 12th, but we do not have any formal recommendations at this time. And we have our next meeting scheduled on September 13th.
Thank you. Consumer Rights and Client Needs.
Hey everyone, Emily Beauregard with Kentucky Voices for Health, and I'm the chair of the Consumer TAC. We did meet in June, on June 7th. We had a quorum. We met on Zoom. We revisited a number of topics that we typically discuss and monitor. I'll just highlight a couple because of the time here today. Earlier, there was a lot of discussion around Medicaid renewals. Of course, that's something that we are monitoring very closely, and we're all, I think, concerned about the low response rate that Deputy Commissioner Veronica Judy Cecil mentioned, with so many people receiving notices and not responding to them. And, just historically, I think this MAC has probably discussed for years, response rates and also bad addresses, or people who, don't have an updated address, the mail gets returned to Medicaid. And we know that before the pandemic, that return mail rate was like between 30 and 40% on any given month. That was pretty standard. The return mail rate now is so low. It is one, I think, partly a good thing, a testament to the work that DMS and the MCOs have done to collect better addresses and more up-to-date addresses. But we do wonder if there are some of these notices being mailed to addresses where people no longer live, and being, actually left there, delivered, not returned to sender. Because during the pandemic, we understand that the Postal Service did have some flexibilities as well and didn't have to verify whether someone was necessarily currently living in at a particular address. So we're wondering if that is partly to, at least would partly explain the low response rate, that mail is being delivered, but not being delivered to, the actual person that it was addressed to, because, they no longer live at a particular address. That's something that I think we need to keep really digging into to try to understand more. And regardless of whether that's the case or not, if we continue to see such a low response rate, I think we really need to look at what kind of community response we need to kind of collectively be working on. And providers, I think, play a huge role in that. If people are getting notices and not understanding them or not opening them because they're getting too many notices, then they just assume that maybe it's junk. They don't understand that it's important. Whatever the case may be, the more providers we have who are looking in Kentucky Health Net, who are identifying that renewal date, making sure that their patient is aware of it, and providing them with assistance, or at least connecting them with a connector, I think that could go a long way in preventing people from losing their coverage simply for not responding. We understand this process. There will be some people who are no longer eligible. That's always the case. But I just can't wrap my head around that being about half of people currently enrolled in Medicaid. And I know that's going to be incredibly disruptive to providers as well, not just to the individuals who, are seeking care and finding out that they're uninsured suddenly. So that part about Kentucky Health Net, I think, is just something I hope providers are aware of and are doing. And something else that we've noticed is that, presumptive eligibility enrollment has been really low for many months now, partly due to the fact that not as many people need it, but also House Bill 7 passed in 2022, which prohibited the state from doing the determination of presumptive eligibility. But hospitals and federally qualified health centers can still use presumptive eligibility. And I'm just wondering how many are, doing that when someone is coming and finding out that they're uninsured, because right now going through reconsideration or an appeals process or a new application, that all takes time. There's going to be a backlog because so many people, there's so much, paper being processed right now, or so many new applications and renewals being processed, that I really feel like we need to revisit presumptive eligibility and make sure that people have that option if they suddenly find out that they're uninsured. And it's because, they just didn't respond to a notice in time. So I think that's something that we all need to be keeping in mind and reminding, providers that is an option. And then finally, I'm going to skip over a few of the things that I put in the report that you all should have, but we did discuss the new dental, vision, and hearing services that are now covered by Medicaid and have been, for this calendar year. And, having talked with a number of providers now, a lot of community health workers, Medicaid beneficiaries, it's becoming pretty clear to us that most people don't think that these services are still covered. Maybe weren't aware of them to begin with because it's been a short period of time, but even those who were aware whenever the services started in January assume that because of Senate Bill 65 that was passed in March, and then the most recent administrative reg review committee meeting in May, where the emergency regs were found deficient. I think there's a lot of confusion, and the assumption being that, because of that bill, because of the deficiency, that the regs aren't in place and active. And I think we're really missing such an important opportunity to get people access to these services. So just want to really raise awareness of the fact that a lot of Medicaid beneficiaries and probably even providers aren't aware that these are still covered services, should be covered for the remainder of this year, and we hope will be permanently covered, which is something we need to work on with our legislators. But that's something that has been concerning to us. Now, we know that there are thousands of Kentuckians getting access, especially to glasses. There are many thousands also getting access to some sort of dental care or hearing aids for the first time. But I think many more would if they knew that this was available to them. And I understand that there's also network adequacy issues there. and providers, being a little reluctant to participate because they don't know what's going to happen with these services. But the services are just so valuable and so life-changing for people and to, health outcomes, generally speaking, that I think we really need to find ways to make them work better for Kentuckians and work better for providers. And then just to that end, we did make one recommendation at our last meeting, and that was that DMS provide communication to providers and connectors about the status of Medicaid dental, vision, and hearing services so that more people are aware and have that information. And then our next meeting will be on August 15th at 1:30 p.m. Thanks.
Thank you, Emily. Any questions? Okay, next up is dental.
Yes, this is Dr. Bobrowski, and we had our last TAC meeting was on May the 12th, and we did have a quorum. And I'm going to tie this in with a short report here with some of the phone calls that the Kentucky Dental Office, Kentucky Dental Association office is receiving. And one of them is that several dentists that, even though we have pushed for and are in favor of the expansion codes, several dentists are calling and say, well, they feel like that the DMS has just ignored the provider. Said we're small businesses out here and we can't keep providing services at below cost. When others, grocery stores, whatever, they get 100% of their costs paid for. Dental gets about 1/3 of our cost pays. The dentists say we've got lab bills, time invested is just below what some of those expansion codes are paying for. Nothing's being done to help stop these failed appointments. For example, Monday morning I had 3 failed at 8 o'clock. Tuesday I had 2. Wednesday I had 2. This morning I had 3 that didn't show up at 8 o'clock. It's just hard to keep doing this. But the other thing is that we just got a call from a lady dentist over towards the Richmond, middle of the state area, that they're doing the dentures and the root canals and stuff. But her comment is that I'll excuse my French and her French, but she said she's breaking her back and are losing her ass, to provide these services. Now, the next thing is that hopefully on a brighter, more positive note, at the Kentucky Dental Association meeting in August, we are going to have a Medicaid forum. The title of it is Kentucky Oral Health 49th, a roadmap to change. I'll be the moderator for a panel discussion with MCOs and interested parties, and Commissioner Lee has agreed to be there. That will conclude my report. Thank you.
Thank you, Dr. Bobrowski. Any questions? Okay, EMS.
Keith is unable to be on today. He got stranded in Maryland trying to get a new ambulance.
Oh dear. Okay.
But they did have a meeting. They have no current recommendations.
Okay. Health disparities.
Hey, this is Jordan Burke. We were able to meet on July 5th earlier this month. We did have a quorum. We had a great presentation over transportation services, looking at value-added benefits and how the different MCOs, are providing those and which ones may be attracting people to actually use those services more and get them involved with it. We also had some discussion looking at interpreter services and how truly accessible and feasible using those are right now, and what ways we could maybe make that a little bit easier, specifically for urgent care appointments, so you don't have to call 48 to 72 hours beforehand, and how that could be streamlined when those patients come in. But no recommendations at this time.
Thank you. Home health care. Hospital care.
This is Russ Ronaldo, the chair of the hospital TAC. The hospital TAC met on June 23rd, and we had a quorum. We reviewed several items, but we do have one recommendation, kind of a caveat. We had not had a recommendation in a long time. We've had a very collaborative relationship with the cabinet over the last few years, but we don't see eye to eye on this one item. In the middle of June, we got a letter from DMS, a hospital provider letter, that told the hospitals that the sepsis 3 criteria would be adopted for sepsis coding and replacing sepsis 2. I sent a report in to DMS or the MAC for this. I'll go through some of the highlights. Sepsis 2 is the currently accepted and adopted coding, and it's a disease process that an inflammatory response to a known or suspected infection. In 2016, the Critical Care Congress adopted a new definition of sepsis, the third international consensus definition for sepsis and septic shocks. That's commonly called now sepsis 3. And it narrowed the sepsis definition and only described sepsis as a life-threatening organ dysfunction. If you go forward in 2018, WellCare began to apply the sepsis 3 definition in their inpatient coding reviews and started to adjust DRG assignment and change payments. We brought the issue through the hospital TAC to DMS, and there was a series of meetings that were held between the hospitals, DMS, MCOs. And the outcome of those meetings was there was a memo at the end of 2019 from Dr. Terrio that instructed the MCOs that DMS would follow sepsis 2, the current CMS and ICD-10 definition of sepsis, until CMS adopted sepsis 3. Fast forward to June 13th of 23, the hospitals got a provider letter informing them that sepsis 3 would be used, replacing sepsis 2. And I put those letters in my packet to the MAC. The hospital TAC was not included in any of the meetings or discussion of the change. The current coding guidelines and coding clinics, so the current coding methodology is, they're all written by 4 parties: CMS, AHA, AHIMA, and NCHS. That's the National Center for Health Stats and the CDC. The current coding guidelines for ICD-10 and CMS coding are sepsis 2, not sepsis 3. And from a coding standpoint, in sepsis 3, there's no sepsis without organ dysfunction. There's only severe sepsis. So you would never see a count in sepsis 3 coded to sepsis. You would either see severe sepsis or no sepsis at all. And that's not, again, consistent with current coding guidelines, coding clinics, coding indexing. So CMS has not endorsed sepsis 3 yet. And so after the hospitals reviewed it, there's numerous concerns moving to sepsis 3. Administrative costs and burdens. We will need to code Medicaid cases differently than Medicare. And with our EMRs, I know particularly with my EMR, our coders code cases. They don't code by payer. So I'm going to, myself and others will have to reconfigure and adjust our EMR to separate the groupings of patients due to the different coding requirements, which will cost us money and will make our coders less efficient. It also have an inconsistency again with what CMS currently does and recognizes as sepsis coding, which is sepsis 2. We have concerns about crossover claims where Medicaid is secondary and Medicare is primary. If Medicaid uses a different coding requirement than Medicare, and how those claims will be adjudicated, denied, have to be appealed, that whole process. We don't believe that the change is consistent with the current regs. The current regs for acute inpatient hospital reimbursement define diagnosis codes as codes maintained by CMS. CMS, again, uses sepsis 2, not sepsis 3. The regulation also assigns DRG grouping to match with the CMS Medicare groupings, which would not be able to be done using just sepsis 3. Quality and mortality, there's some a blurb there, but essentially when you change the coding, you'll have different DRG assignments for those in sepsis 3 that are in sepsis 2, and depending on how you compare outcomes between patient groups across states, between payers, you could see, I know when WellCare denied those back in 18, we saw sepsis being regrouped to UTI. So you have the potential to see mortality and DRGs like UTI, and then suggesting the hospitals are providing poor care to not very sick patients. There's payment impact. Lots of organizations are pushing, even DMS through the HRIP quality goals that we're currently under, are pushing for recognition, diagnosis, and early management of sepsis. So one of our HRIP quality goals is sepsis screening in the ED and use of sepsis bundles early in care. DRG payments are supposed to match the payments for the cost of care, and when you eliminate that code for sepsis and only allow the coding for severe sepsis, it's going to change the DRG assignment and reduce payment. When we ran into this in 2018, the sepsis denial showed an average case impact of more than $4,000 per case. The Hospital Association also has voiced numerous concerns, and I've attached that letter in my packet to the MAC. The recommendation is the hospital TAC recommends that the MAC advise DMS to repeal Hospital Provider Letter A263 dated June 13th, 2023, and that letter changed hospital utilization management and coding to sepsis 3 criteria.
Okay, is that
That's a report. Any questions I can answer?
any questions?
I have my hand raised.
Go ahead, Nina.
Yeah, not a question, but just to reinforce the very significant importance of the cabinet responding to this request very quickly. The guidance in that June 13th letter that Russ talked about gave instruction to basically do something that CMS and ICD code or ICD-10 coding is not consistent with. And so it's very critical that this matter be addressed.
Thank you.
Thank you.
Next, intellectual and developmental disabilities. Nursing home.
This is Terry Skaggs. I am chair of the nursing home TAC. We met on June 14th. We heard details regarding our July 1, 2023 rate setting. We heard a report on the Medicaid unwinding and did ask for a specific breakdown specific to long-term care. And we should be able to see that at our next meeting. We discussed the transition of our assessment methodology. The current system sunsets September the 30th, and we're working with Medicaid to assure that the transition of the methodology, which actually sets our rates, is case mix neutral. We discussed scheduling of a rebasing that is due July of 24, both in our price and capital components of our rates. We're working with Medicaid right now to assure that there's adequate funding in the budget for the next biennium to pay for the rebasing. We're also working with them to determine the timing of the capital appraisals that'll be used in that rebasing. And I actually have a call tomorrow with Medicaid to discuss the methodology for that rebasing. Medicaid rates have not been rebased since 2008. So it's very important to our provider group that this rebasing is done correctly. And unless there are questions, that's the Medicaid TAC.
Any questions? Okay, thank you.
Beth, Rick
Yeah.
with the IDD TAC just logged in if you wanted to go back for a report.
Okay. We'll go back to intellectual
Thank
development.
you. Thank you for that. Been dealing with a lot of issues here. Yes, we had a meeting and there was a quorum. I think probably the one thing that would of note is we noted that there's another waiver being worked on, a children's waiver. Basically, it's a feasibility study right now that would serve children who have mental illness, autism, or another developmental disability. And that concludes my report.
Okay, thank you. Nursing services? Optometry?
Steve Compton, a member of the optometric TAC. We have not met since the last MAC, so we have no recommendations. We do meet next Thursday. That's the end of my report.
Thank you. Persons returning to society from incarceration?
Yeah, this is Steve Shannon, Chair of the TAG, giving the report. We had a quorum, we received updates from Medicaid and our MCO partners, and we have no recommendations, and we meet September 14th. Thank you.
Thank you. Pharmacy?
The pharmacy TAC did not meet since the last meeting. Their next meeting will be on August 9th. Thank you.
Thank you. Physician services? Primary care?
Yeah, this is Barry Martin. Thank you, Chair. We met on July 11th at 11 a.m. Via teleconference, and I sat in as chair for Patrick Merrick in his absence. And we met and we got an update from DMS and the MCOs. And we did come out with a recommendation. We've been working with the DMS and MCOs about standardizing some quality care measures, and the MCOs and DMS come back with some, and we just wanted to make a recommendation to the MAC that we have a little more collaboration and input with those standards of care, coming up with those standards of care, and having some mutually acceptable standards. That's our recommendation.
Okay, were you not satisfied with the standards?
No, we did. We were kind of given the standards. We would just want to have a little more input, and we would like to have been involved in the discussion before being given to them. We'd like to have some input on responding to them, and is all we're asking for.
Okay, thank you.
Barry, this is Erin. Do you mind to follow that recommendation up to me in an email, please?
I can.
Thank you so much.
Thank you.
Any questions? Okay, therapy services. Okay, that concludes the reports and recommendations from the tax. Would somebody like to make a recommendation to accept the reports and the recommendations from the tax?
Beth, it's Nina Eisner. Can I go back to the hospital TAC, the urgency of my recommendation of supporting that? I would like to make a motion that the MAC accept the TAC recommendations.
Okay, that would what we're doing right now is accepting them in total.
Okay, so we don't need to specifically state why it's so critical to accept the TAC recommendation for hospitals.
I think that we need to note that, but typically we just accept the recommendations in total for the tax.
Okay.
Let's put a special notation there about the urgency for response to the hospital TAC.
Yes.
Okay, would you like to make a second?
Yeah, I'll second.
Thank you, Barry.
That's great.
Any discussion? All in favor, say aye.
Aye.
Anybody opposed? Okay, recommendations are accepted. Okay, and moving along here, the next item is actually something to include on the September meeting. And this has to do with the MCO's report of 98 to 99% adequacy and compliance for services. But Kentucky's third-party quality contractor, iPro or secret shopper reports show only a 30 to 40% compliance. So there's a concern about adequacy of compliance that does not address actual accessibility of services. So the MAC requests a report from DMS at the September meeting addressing the discrepancy between the MCO reports of compliance versus the iPro report. And then next up is item 9. Physician locum tenens may bill under absent physician provider number using a modifier. The locum tenens physician is not required to be credentialed with Medicaid to do this. Many nurse practitioners, nurse midwives are establishing practices and require coverage for their practices when they're on vacation or absent due to illness. So we're requesting that Medicaid regulations should be amended to afford APRNs the same opportunity as physician practice owners. And that would be a recommendation coming from the MAC. So I would ask if somebody would make a motion to accept that recommendation in a second.
I'll move that. Beth, this is Sheila Schuster.
Thanks, Sheila. A second.
This is Barry, I'll second it.
Thanks, Barry. Any discussion?
Beth, do you
I'll-
mind to follow that up with me in an email, please? This is Erin, sorry.
Yeah, sure.
Thank you.
You want me just to repeat this in an email?
Yes, ma'am. I do my best to capture everything while I'm taking notes, but when it comes to recommendations, I like to make sure I have them in writing so I know exactly the ask and I don't miss any information.
So the ask is exactly written.
I'll copy it from the agenda. Thank you.
Okay, thank you. Any discussion? All in favor, say aye.
Aye.
Anybody opposed? Thank you. And next up, item number 10. Let me find the explanation. Our members who are duly eligible for services, Medicaid and Medicare, or Medicaid in a commercial insurance, going to be moved from MCO to FFS or fee-for-service status. And the background on that is, after years of effort and urging by the behavioral health community, we now have a solution that's working to make sure that providers are able to bill and get reimbursed by the MCOs for services rendered to dual eligible individuals. DMS worked to provide a bypass list for those who had Medicaid and Medicare, but the commercial insurers presented a much bigger problem because they vary in which services they provide coverage for and reimburse. The MCOs worked well together to come up with a separate bypass list for commercial insurers, and while it has only been in effect for about 2 months, it is working very well. We thought the problem was solved, but now we are hearing that DMS is thinking about moving all of the individuals who are duly eligible from MCO coverage to fee-for-service. And we would like to know the rationale for this, and it is strongly being considered. So again, this would be a recommendation coming from the MAC. And so we need a motion and a second.
Beth, this is Sheila. It's a question first.
Okay.
I mean, I want to know if it's being considered, and then we need to be able to make a response to it, I guess, is my thinking about it, about putting it on. And I don't know if anybody is on in Medicaid and can respond to it, or if it needs to roll over to the September agenda.
Okay. What is Commissioner?
Yes, hi, this is Lisa. Can you hear me?
Yes.
Okay, great. Thank you. Yeah, we had been looking at moving some eligibility who had third-party liability over to the fee-for-service, but that has been put on hold. We are not looking at that right now. So No, it's not being considered at this moment.
Okay, so we don't need to do anything about this right now.
No, not right now, no.
Okay,
Well,
great.
let me request then, Commissioner, that if it's being considered again, that those of us who have worked so hard on this issue, both from the MCO perspective and the provider and the consumer perspective, be included in those discussions.
Yes, well, if that is brought up again, that if we are thinking about moving those individuals with third-party liability to fee-for-service, we will bring that up before the MAC and when and if the discussions begin.
Thank you. And I would like for the BHTAC to particularly be involved. Thank you.
Okay, thank you. Any other business? Okay, then the last thing on our agenda are nominations for the MAC chair, vice chair, and secretary. My term on the MAC has expired, and I will continue to serve until I have a replacement. But in all fairness to the MAC, I felt like I should not run for chair. So the positions, we're taking nominations for the MAC chair, vice chair, and secretary today, and then we will vote at our September meeting.
I would like to put my name in nomination to serve as the MAC chair. This is Dr. Sheila Schuster.
Okay, anybody else? Okay, vice chair.
This is
Second.
Garth Bobrowski. I'll put my name back in the hat for vice chair.
Okay, thank you. Anybody else? Okay, and then secretary. I think Mackenzie is not on the call today, but she is our current secretary.
I'll recommend her to sustain
I agree.
that'll be her punishment for missing today. This is Barry.
Thank you, Barry. Erin, would you let Mackenzie know?
Yes, ma'am.
Thank
Madam
you.
Chair, I think we ought to cease the nomination now and approve as submitted.
Okay, thank you. Okay. So somebody want to make a motion to adjourn? We're about 15 minutes over time, and I appreciate everybody staying on.
Did we have?
I
to
just,
vote?
before a motion to adjourn, I'd like to thank you for your service as chair of the MAC. Really appreciate it and your leadership. So thank you. And now I'll make a motion to adjourn.
Chair Parton, do we need to vote on the nominations or?
We'll just vote at the next meeting.
Okay.
Thank you, Nina. I appreciate that. And as we all know, when our terms expire on the MAC, we're just gone and we don't get a chance to say anything after we leave. So I appreciate that. Thank you very much.
I'm sure our paths will cross again. Chair Parton.
Probably so.
I think there is unanimous appreciation, Beth, for the many, many years that you've served as chair and really moved the MAC into being, I think, a much better functioning and more important part of the policy determination for Medicaid. We have excellent communication with DMS, and I intend to build on everything that you've done. You've left me difficult shoes to fill, but we all appreciate everything you've done for the MAC and for the people that the MAC serves and for all the providers of services.
Well, thank you, everybody. So we have a motion to adjourn. Second?
Second.
Okay. No problems with that one, huh? All in favor?
Aye.
Okay, thank you, everybody. See you in September.
Yeah.
All right.
Thank you.
Thank you.
Thank you.
Bye-bye.